Okay, so we'll go ahead with our routine question. Already I have introduced my panel. So these are the majority of the problems what we come across is the nocturnal analysis, seizures or epilepsy, headache, syncope, autism, ADHD, and list is long. So this is a 12-year-old girl brought with history of collapse during the prayer. Child was developmentally normal and just standing in the queue for the prayer and suddenly collapse and recover within 2 minutes. There is no other significant history, and within 2 minutes, I think teacher informed the parent that this episode has happened and asked to get the detailed workup done. So first question to ma'am, sudden collapse, what are the differential diagnoses, Neeta ma'am?
Collapse is due to sudden shutdown. It's like switching off the light. Sudden shutdown of the either perfusion, blood supply to the brain or oxygen supply to the brain. So usually neurological causes like the atonic epilepsy is very common. Then other epilepsies like myotonic, clonic, tonic seizures, but they are associated with the movement disorders. And many times we have to rule out cardiovascular causes, which gives the hypoperfusion like the tight aortic stenosis, coarctation of the aorta, cardiac myopathy. Even drug intoxication and syncope is very common. In this case, it is orthostatic hypotension. In dengue fever also, we come across the hypotension and collapse. Many times, even the painful prick can give collapse. Many times, it is very common in our office practice that when we prick the patient, immediately child collapse because of the pain. And after that, parent also collapse. Many times, it's very common. And even bad smell, emotions can lead to collapse.
So Dr. Vishwanath, what is syncope?
So syncope is transient, sudden loss of consciousness and posture, tone. So there are two components, one is tone and one is consciousness. So there should be loss of, both, and which is reversible, and it is due to the decreased blood supply to the brain. That's it.
Okay, if there is a component of GTCS or tonic-clonic movement, do you call it as a still syncope or do you call it as a seizure?
Yeah, so again, syncope, when there is setting, for syncope there should be setting. There should be prodrome and there should be precipitant. Now this girl was standing for a few hours in the assembly and then there was, precipitant. She was standing. Now whenever she follow something, she might show some tonic posturing, uprolling of eyeballs. So that is a seizure which is non-epileptic. Okay? So I would consider it is a non-epileptic seizure.
So can we call it as a reflex seizure or a hypoxic seizure because of the lack of, so it is not epilepsy you mean to say?
It is not epilepsy.
Yeah. So still the point to consider is in syncope still you are able to see the tonic-clonic movement and sometimes can be confused with the epileptic seizures. So what are the investigations you suggest for the
there is as such no investigation choice. It depends on which situation syncope. As this case, child was in school standing for a long time. I think history and clinical examination is more important in this. Suppose this type of syncope occurs while child is playing or is doing some activity, then you need long lead to EEG to rule out any QRS abnormal, long QTC syndrome. Suppose this type of syncope happens in the morning hours and child has prolonged post-ictal stage. We can go for EEG, long lead to especially sleep deprived EEG to rule out any, especially such kind of adolescent female girls to rule out any juvenile myoclonic epilepsy. Sometimes complex partial seizures or atypical absences, they may present like this. So we can go for EEG. MRI per se requires whenever there is a focal neurological signs or whenever such kind of syncopes, they are associated with ataxia, syncope or any cerebellar signs. We need to go for MRI to localize the any CNS abnormality. For
okay. And welcome respected Dr. Gopal Rao sir, our first pediatrician from the Latur district. So when will you go for the detailed cardiac evaluation, Dr. Maruti, Dr. Shirish?
In history wise, if you get a history of syncope or a history of while doing exertion or some activity, that is exercise-induced syncope what we call, get a family history of sudden cardiac death in a young patient to rule out hypertrophic cardiomyopathy like conditions. Second is any preceding chest pain while having a syncope, patient complains that I was feeling giddiness and it's a chest pain. You go for cardiac evaluation, or you find some findings, you get a abnormal murmur while examination, you can go for cardiac evaluation for echo.
Okay, and what about the management?
Family advice. If it is simple syncope, then you have to explain the benign nature of syncope. If child is older, then you should advise him to recognize the prodromal symptoms like nausea, epigastric discomfort, blurring of vision, lightheadedness. And it is also explained to child that he should avoid certain precipitating factors like prolonged standing, irregular meal times, to avoid dehydration by maintaining hydration, sudden change of posture, to have adequate daily water intake, at least 3 to 4 liters per day. And if after syncope he takes long time to regain consciousness, then you should consult the other specialists like cardiologist or neurologist for further evaluation of syncope.
Okay, one scenario, Dr. Vishwanath, if the suppose treating physician has referred for EEG, just doubt that he may be dealing with seizure, it is clear-cut syncope. But he get an EEG abnormal reporting, then what to do? Whether to start antiepileptic or not?
Yeah, this is a very tricky question. Now you are having a patient, you think, look, precipitant there, prodrome there, and the child come with EEG, and which is reported by the abnormal EEG. Now, basically being pediatric neurologists, we are having our own standards of reporting, because there are multiple, things in the pediatric EEG which can be confused with the abnormal generalized epileptiform discharges. Now, because it is being reported by our own brother colleague, so we can tell, okay, we can get one ECG done, and we can repeat one EEG if at all it is required. But in evaluation, most important is ECG with long lead 2, to look for the QT prolongation and to look for the PR interval. Apart from that, EEG won't become the part of investigation as far as typical syncope is concerned.
Even so, take home message is even EEG is abnormal, and if you are very sure that it is a syncope, no need to start, because pediatric EEG there are few sharp wave or transient waves or abnormalities reported. It is very common, but you need not to treat such EEG if the clinical support is not there. We should be aware of long QT syndrome in kids when we are dealing with a syncope. So this is a 7-month-old child, and basically delayed from the beginning, and this is a kind of episode child is getting. These are after getting up from the sleep, daily around more than 50 episodes, and child is global developmental delay. Since beginning, child is very cranky. So what is the differential diagnosis, ma'am, when you sit in the OP and child comes with jerking movements, maybe after getting up from sleep? So what are the differential diagnoses we should think of?
Jerking is actually fraction of the group of the muscles or single group of the muscle. If it is flexor means it is myoclonic jerks, and if the duration prolongs and along with the trunk and neck movements involved, then it's spasm. And if it is rhythmic, then it is myoclonic jerks. But many times we come across the neonate jitteriness and the shuddering movement. That is also jerky movement. And even in the deep sleep, NREM sleep, there is a myoclonic jerks in the infant, which is very common.
So physiological myoclonic jerks is very common. So we should be aware. But at the same time, I think we need to find out developmental history, then birth history, whether there was a hypoxia or not, and global developmental delay, or there is a neurocognitive delay is there after starting this. We need to correlate everything. So what is the semiology of epileptic spasms?
So semiology is how spasm looks like, how you can describe a spasm. So whenever there is sudden jerky flexion of neck, limbs and lower limbs, or when the trunk, it is called the typical salam spell. What is the sudden jerky movement, the flexor spasm. But at the same time, West syndrome need not to be just flexor spasm. If the child flings arm, that can be extensor spasm also, or it can be asymmetric and mixed variety.
So everyone should be aware it is not typically salam attack they present with sometimes hemispasm, sometimes extensor neck thrusting, sometimes just simple jerking may turn out. So what is the investigation of choice, especially in a peripheral event?
So investigation wise, the best thing will be to tell the parents to make a video of the event. They describe it, but video will tell you everything. So always we tell patients to make a video. If they can contact us, just send us on our WhatsApp. If not feasible, if they are in a remote area. So you can tell it's flexor spasm, extensor spasm, mixed variety, whatever it is. The other investigation, bedside investigation can be done is electroencephalography, EEG. You get hip arrhythmia pattern, a burst suppression pattern, very common. Third, if it's a symptomatic West syndrome due to particular cause, like birth asphyxia, hypoglycemic brain injury, then neuroimaging is required and MRI brain is the investigation price in that. So these are three common investigations we commonly do in a child with a West syndrome, symptomatic or idiopathic.
So what is the Ashwin, typical West syndrome consists of? And obviously Dr. Shirish, nowadays availability of the smartphone even in a small village is very important. Just ask them to record the event and present it.
Epileptic West syndrome is the most common and most severe epileptic encephalopathy that's exclusively seen in less than 1 year of age. It has three components. One is infantile spasm or epileptic spasm. Second is hip arrhythmia. And third one is cessation or a regression of cognitive-motor milestone. This is exclusively seen in less than 1 year of age.
So it is typical child of developmentally delayed or developmentally normal child. Started with spasm initially, less frequency. It is more of a hypnagogic or hypnopompic convergence, that is before going to sleep or after going to sleep. There is neurocognitive delay and then EEG suggestive of typical hip arrhythmia.
And it occurs in clusters. There are
clusters. Yeah. And you want to describe the EEG, Shirish?
So basically, if you look, this is a chaotic background. There is no background activity seen in this EEG. There are generalized slow waves. Along with there is decrease in background activity. These are known as burst suppression pattern. The burst is lasting for almost 1 second, followed by a suppression of the background activity almost 1 second again. So it's a severe form of burst suppression pattern in this EEG.
Yeah, reporting treating physicians sometimes should be aware. This EEG sometimes may be reported as a generalized epileptic form discharges or seizure disorder where they diagnose in clinic, but when they get the EEG of generalized, they start with cardinal, and if they get a report of hip arrhythmia, obviously now everyone is aware what to start. So what is the treatment protocol?
Treatment of West syndrome or epileptic spasm is directed towards to control the seizure and to improve the background activity on EEG, which helps to relieve or stop further encephalopathy in that child. Ideally, the injection ACTH is the first line of treatment in cases with epileptic spasm or West syndrome. It is given as a high dose or low dose regimen. Low dose regimen is now popularly. It is started as 20 minutes per day for 2 weeks. If there is complete seizure control, then we can taper and stop in next 1 week. If the seizure persists despite 2 weeks course of 20 minutes per day, then we increase the dose to 30 minutes per day and try it for 4 weeks. Later, if seizure controls, then we taper and stop. This is low dose ACTH regimen. In certain children, like children with tuberous sclerosis, vigabatrin is the first drug of choice. Also, there are many studies in which oral course of steroid for 4 to 6 weeks helps to decrease or stop the seizures in West syndrome. Routine anticonvulsant drugs are not first line, they are also always second line for refractory seizures. And for refractory cases, other things like ketogenic diet or sometimes surgical resection of focal lesions may also be beneficial.
So basically, see, when we are working in a place like Latur or district places, what we need to understand, sometimes ACTH may not be feasible for the parents to take it at a local level. So equally prednisolone is effective if it is started in an effective dose, but has to be monitored with the blood pressure and sugar, and BCG injection or live vaccination should be avoided. I prefer to give the red line, avoid live vaccination for next 3 months. So this should be the guideline. If you are starting the immunotherapy, that is ACTH or prednisolone, you have to clearly mention into your note that live vaccination should be avoided, and we need to monitor for sugar and BP. try to, like in peripheral setup, oral steroids like prednisolone can be given. ACTH is also effective. Vigabatrin is the drug of choice in tuberous sclerosis. The day you start, within 1 week, child will be seizure free. Drastic improvement will be seen. Do you need to repeat the EEG in these cases? Because sometimes we need to repeat the EEG every month also in these cases. So do you repeat it?
Now, as far as this tuberous sclerosis is concerned, now the recent guidelines wasn't it that you put the child on EEG surveillance, even though there are no spasms, start doing EEG from 2nd or 3rd month. Let it be normal. You try to pick up some kind of the child is having before epileptic spasms, the child may show electrical spasms, and then treat. And once you treat, as Dr. Prashant told, you find drastic response. One thing I would like to say that epileptic spasms, it is a medical emergency. If you do not have ACTH, start on steroids, oral steroids. Yes. It will work.
True, very true. So it is an emergency to treat the epileptic spasms or a West syndrome. So what are the other available options for this refractory West syndrome? Just name it. Refractory West syndrome. What are the other options? Newer antiepileptics.
Benzodiazepines like clonazepam, pyridoxine, topiramate, these are quite beneficial.
So nowadays what we are using is a brivaracetam and parampenal, whereas genetic epilepsies or genetic West syndrome, they are responding very well. It's like we need to complete this one. So this is a 15-month-old child with delayed cry at birth and subsequent developmental delay, spasticity of all limb with relative better cognition. One more child. So this is the MRI, and you can clearly see there is a hypoxia. So this is a clear-cut case of spastic quadriplegia. But this is a child who was normal crying but developmentally delayed, and this is the MRI. So anyone want to describe the MRI or correlate? Clear that there is no history of birth asphyxia.
Looking at the child, if you look, there are light brown hairs of the child, and even eyes are light colored, grey colored eyes. And in MRI, if you see, there are hyper intense signal. This is a flare image. So you get hyper intense signal at periventricular area, and with mild dilatation of ventricles. So clinically, I will go with it could be PKU.
Okay.
Leukodystrophy
versus PKU, then we need to go into the details, but every case of developmental delay is not the cerebral palsy. So for audience, there is a quiz. There are 2 videos. This child is referred to be for the developmental delay, gross motor delay. Anyone want to comment on this from PG students? Or anyone from panel? Just look at the eyes of the kid and even the mother's video.
It's myasthenia gravis.
So it is the
eyelids of the mother is also.
Yeah. So both of you, if you see, there is a drooping of eyelid clear cut. So this is a myasthenia gravis, obviously. So what are the CP mimics now?
Cerebral palsy is not a single term. It's actually a group of the disorder or the syndromes in which there is non-progressive motor impairment, and that is secondary to either brain lesion or anomalies, congenital anomalies in the brain.
Vishwanath, like CP mimics?
CP mimics, yes. In day-to-day practice, we have to first consider whether there is any setting for the cerebral palsy. That is the first question I asked. Whether there is prolonged second stage of labor, whether mother had some hypertension. Baby did not cry after birth, it cannot be a CP. You have to always, when the baby cries after birth or doesn't cry after birth, it is not going with the clinical history. It is not going with the examination. Think about metabolic causes, think about genetic causes, and there are few conditions.
We have findings, don't worry.
So neurometabolic conditions like, arginase deficiency, it mimics like spastic diplegia. Hereditary spastic paraparesis, it again mimics like your spastic diplegia. Neurotransmitter disorders mimic like dystonic CP, Segawa disease. So, not all developmental delays or developmental regressions are CPs.
And one thing, while asking history, please don't point out again and again कि delivery के रोया था नहीं रोया था. They will blame gynecologists there. So please make sure कि don't put blame on them. Ask history, but be little
cautious?
Yeah, mainly especially for the PG student, don't see that it is a developmental delay or known case of cerebral palsy. Always there is a room to think of the pattern of the development, family history. So what are the causes of, Dr. Ashwin, for the CP mimics?
Why we need to think about CP mimics is, few of them are treatment is available, and rest of them require genetic counseling. Basically, routinely what we comes across is, as he said, is familial spastic paraplegia, even biotinidase deficiency, even Menkes disease, Wilson's disease, they mimic sometimes as a cerebral palsy. Few like leukodystrophies like white matter disease, beta lipoproteinemia, then Krabbe's disease, then very long chain VLCD, short chain SCLD. Treatment is available for this. So whenever such kind of patient comes, then commonly like DOPA responsive dystonias, they will present as a spastic dystonia, and once you diagnose, treatment is available for such cases. Simple cases like autism, they will come with tiptoe walking and all those things, and when you take careful history and examination, you can easily rule out CP mimics for such cases.
Yeah, last week only I have come across child has been referred to the pediatric orthopedician for Botox injection, but this child was having intermittent toe walking. So we need to aware that it's not too uncommon. So this is just Potter in morning lecture has shown. So what's like clinical diagnosis before and after treatment?
It could be clinically biotinidase deficiency, loss of hair in the first picture of the child with some ulceration around the angle of the mouth, and after treatment the hairs has come up and even the ulcer has gone. So could be a biotinidase deficiency.
Okay, so now we left with very less time. So just moving towards directly 2 videos we will play. So just audio is running. इतला आवाज येईल. नाव सांग तुझं. नाव सांग.
If you look at the behavior of the child, he looks like more autistic. No response to verbal commands or voice command. He's into his own play. Poor social interaction. Could be autistic child.
So this child, if you see, we are trying to call him, but he is not giving eye-to-eye contact, not responding to the sound, and so it is a speech delay and social communication delay. Now, voice is there. So this is again one of the child with Dr. Ashwin. What is the clinical features of ASD? Very important to cover last case.
Clinical features of ASD, autistic spectrum disorder. 3 basic features are there. One is disturbance in social interaction. Second is disturbance in social communication. And third is disturbance in imagination and behavioral issues.
And one more is repeated restrictive behavior is one of the criteria. How to diagnose it? What is the, how to?
The sound is coming from outside. So to diagnose, there are screening test and two definitive tests. The screening test which we do is the chat or MChat. There are different based questionnaire based studies, and the CAS, that is the clinical autism rating scale, that to diagnose the autism.
So these are the like CAR score and MChat we need to, in a pediatric OP practice, we need to see. What is the screen time recommended? This is very common question even for young pediatrician who are dealing with their younger ones. What is the screen time recommendation guidelines?
So ideally no screen time for everybody. However, if we try to categorize, say less than 6 months, no screen at all. And from say 1 to 2 years, 1 to 3 years, it is very minimal, that is less than 30 minutes per day. And 3 to 6, it should be interactive only, and 6 to 15 years, 1 hour, that is interactive only. But however, avoid screen.
So, okay. So, see, very practically question asked by the parent, we want to show the screen while feeding only. How to stop that practically? What is your advice for the parents?
म्हणजे लहानपणी मी म्हणतो माझ्या लहानपणी इथे एक चिवचा घास कवचा घास ते तर आता गेलेलंच आहे. समोर मोबाईल ठेवलं की आईचे काम सोपं होतं, त्या बाळाचे काम सोपं होतं. ओके, सो देर इज नो शॉर्टकट. इफ चाइल्ड बिकम ऑटिस्टिक बिकॉज ऑफ स्क्रीन विच इज कॉल्ड व्हर्च्युअल ऑटिझम and it's the emerging, say again, emergency, so you have to restrict screen time.
Yeah, so practically what we need to engage the kid by giving your own time. To share my practical experience, yesterday I was at Jaipur airport. My child was not able to feed, so my wife was suggesting to switch on the mobile. But what I tried, I took 45 minutes to feed my baby. One spoon, I go to the shop, again one more round. So you have to engage the child meaningfully, give your the meaningful time or the quality time. Nowadays, parents don't want to spare the time, just they want to come to the pediatrician and say, make my child normal because I am paying you the fees. But it is autism is the case where you need a parental counseling first to accept that there is autism, then act on that and decrease your screen time first and then decrease the kids' screen time.
So one more thing. Earlier there were joint families. So many kids together, they used to eat together. But now because of nuclear family, no social thing along with that, that is creating more problem. That is personal.
True. I think before treating autism, we need parents counseling first. Most of the parents, they are not in the mind to accept that their child has few problems. आमच्याकडे जे कोणते पेशंट येतात त्यांनी डॉक्टरांनी पाठवलं म्हणून तुमच्याकडे आलो, आमच्या बाळात काहीही त्रास नाही. दॅट इज द सेंटेन्स की या डॉक्टरनी तुमच्याकडे पाठवलं म्हणून आलो. तो फर्स्ट 15 to 20 minutes यू हॅव टू काउन्सिल देम की युअर चाइल्ड हॅज दिस प्रॉब्लम अँड दिस इज ॲक्च्युअली अ प्रॉब्लम. दे आर नॉट एबल टू अंडरस्टँड की दिस इज द प्रॉब्लम की माझा बाळ मोबाईल बघतोय आणि ऐकत नाही. दिस इज नॉट अ प्रॉब्लम दे थिंक. So 15-20 minutes you have to spend to counseling the parents first. Then you need to start that.
True, कारण हा मुलगा नॉर्मल गाणे राइम्स म्हणतो बट तो बोलू नाही शकत आणि कनेक्ट नाही होऊ शकत. थँक्स फॉर द ऑपॉर्च्युनिटी MARPCON.
Thank you, Dr. Prashant Udge, sir.